Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins. I'm a family medicine physician and senior physician advisor here at the AMA. A career in medicine takes its toll. From the MCAT to clinical clerkships, from your intern year of residency to being a mid-career attending, from planning for the winding down of your career and planning for retirement, stressors are everywhere. The volume and pace of work can certainly be overwhelming, not to mention the intensity, sometimes literally life and death. The adverse effects of stress and strain have been known for decades, and we aren't immune to them. But physicians aren't always willing to admit that we're struggling. When we do come to that realization, we don't always get the help we need when we need it. Nearly every day, a physician in the U.S. commits suicide, a rate more than double that of the general population. While there's certainly not a single, simple fix for this situation, sharing and listening to real stories from real people who've lived it, healthcare workers with firsthand experience navigating burnout and depression, is one way to help break down the stigma around mental health and asking for help. I'm joined by Dr. Michael Ivey, a trauma surgeon and chief medical officer at Gaylord Specialty Healthcare, a leading healthcare system exclusively dedicated to medical rehabilitation in Connecticut. Thank you for being with me and for being willing to share your personal experience and journey with our listeners, Dr. Ivey.
Oh, thank you, Kevin. I'm excited to be here.
Before we get started, I know that you're a veteran of the U.S. Navy, and I'd just like to say thank you, sir, for your service to our country.
Thanks, Kevin.
Could you tell our listeners a little bit more about yourself and your background, please?
Sure. I grew up in the Navy. My dad was a Master Chief. So when it came time to apply to medical school, I joined the Navy to pay for medical school. Did my internship at the Navy Hospital in San Diego. Spent a couple years in the Marine Infantry Battalion as their doc. Finished my residency in San Diego in general surgery. Went to a fleet surgical team out of Norfolk, Virginia, so deployed to the Med. Then I got out of the Navy, went to Yale to do the Surgical Critical Care Fellowship, and became a trauma critical care, acute care surgeon, at New Haven and then at Bridgeport, later at Hartford. I took on a variety of different kinds of roles. I was the associate program director for the Yale surgery residency at one point, the chief of trauma at Bridgeport, the associate director for surgery at Hartford, the VP for quality at Bridgeport, the chief medical officer there, the interim CEO for a while, the deputy chief medical officer for Yale New Haven Health System, for a number of years. And then now I'm the chief medical officer here at Gaylord. That's kind of where I am.
Pretty impressive CV.
Yeah, that's a lot over time. I can't hold a job more than 15 years.
Well, you got to keep moving before they catch up to you. And your current position at Gaylord Specialty is relatively recent or new?
Yeah, no, that's right. Just started here in March.
Well, great. Well, thank you for being with us and visiting with me today and being willing to share your personal experience. Could you sort of take us back to where did your experience with burnout and or depression start?
Yeah, you probably have to go back to like late 2001, beginning of 2002. I was a pretty busy trauma critical care guy. I loved that work. Right. I love trauma and critical care and emergency general surgery and burns. That's all teaching the Yale surgery residents. That was all great stuff. The Yale surgery residency had gotten in trouble a little bit with the RRC. Some of your listeners will know, there was a lot of change going on in GME at the time. And so we got on the wrong side of that. So I was asked to become the associate program director to kind of help, create a new program. Originally, there was going to be time set aside for me, some freed up time. That really didn't happen. So I kept working, full time as a clinician and just took on a lot of extra work, in January 2002. By that summer, I've been working hard for quite a while at that point. It's definitely starting to feel burned out. In retrospect, I'd gotten, I was tired all the time. I was pretty cynical about the world. So a bunch of things like that. The good news is we got the new program got approved, and so we had a little celebration. But then the guy who's the chair at Bridgeport left, so the chief of trauma became the chair, and I became the chief of trauma, which was great. It had been a career goal of mine, honestly, but it meant more work because the the chief trauma was now the chair. And so he was not able to work as much clinically as he had. I mean, he still took as much call as anybody, and he just wasn't able to kind of carry that same clinical load. And so it was just more work on us. And yeah, me and the guys in the section, Phil and Dan, we got pretty burned out. 2002, we were just, and again, in the trauma world, it was talked about back then, because we're still, working kind of crazy hours. So we knew we were just burned out. We said, just suck it up. It'll be all right. We'll just get through this. But, it just didn't go that way for me. I think that I kept thinking I could find a solution to this problem, because I'm very good at solving problems. And I just couldn't find a solution. And I think that what ends up happening is, you miss a ton of things with your family. You're not there for, school meetings. You're not there for, Little League games or concerts or, any of that kind of stuff. You're missing it all. And, I mean, dinner or breakfast. I mean, you're just missing your life. And I think that, one of the things that you have to worry about is you start to blame yourself for it. Even though it was, there were a lot of the factors were really outside of my control at that point in some respects. So I just kept blaming myself. And so every day, and I would ruminate on it. And I would advise people not to do either one of those things. Yeah. And I was also relying on my partners a lot, because I had to go to meetings for the residency or try to get home for different things. And, I'd say, hey, can you cover this gallbladder? Can you do this? And we were great colleagues, but again, you do feel like you're imposing on them a lot as well. And so at both sides, you feel like you're letting down the people that you care about the most. At some point that winter, 2002, 2003, I think that things changed. I think I went from being burned out to really being depressed. I mean, I didn't realize it at the time, but, suddenly the joy goes out of things. You lose hope. I don't remember when I lost hope, but I lost hope. I lost hope that things were going to get better. And I always had a lot of confidence in my ability to fix things, and I just lost hope. And so, it just, it's a very dark place. I mean, you're sad almost all the time. It's hard to find joy in the world at that point. You start having feelings like, well, if I die, it wouldn't be so bad. It wouldn't be so bad if I died. And then, from there it's not a big jump to kind of thinking, this is just the way my life's going to be. And then you kind of start hoping that you'll die. And it's a small jump from there to think about ending your life. I'd done trauma for a while at that point. It seemed plenty of people die. It didn't take me long to come up with a plan. I would drive into work, and I wouldn't act on the plan, because, I just didn't want to do that to my kids. I think that I'd known some kids growing up whose mom had died from suicide, and, it was just really hard on them, just so hard. And I just couldn't do that to my kids. But then that just meant I just sucked it up another day. And then one day I'm driving into work at the VA. Actually, we covered the VA in West Haven too, the SICU there at the time. And I'm driving across the bridge, and it occurs to me, I remember a lecture from med school, and what the psychiatrist had said is that when you're evaluating people for depression, you need to find out if they have been thinking of harming themselves, and you need to find out if they have a plan. Because if they have a plan, they need to get help quickly. And that was really, it's hard for me to believe in retrospect. That was really the first time I recognized that I was depressed and suicidal. I just did not recognize it until that point in time. And then I'm like, then what do you do? So drove into the VA and around it in the CQ, and I called the chair of surgery there, a remarkable kind of woman, Ronnie Rosenthal. I said, hey, Ronnie, I'm really struggling. Do you mind if I come up? And Ronnie was great, of course. She's like, yeah, come on up. Of course. I kind of just broke down. I don't really remember exactly what I said. I don't really remember exactly what she said, but I really opened up, about how I've been feeling. And I took a few weeks off. I started, she arranged, got a number for a psychiatrist, so I started seeing him right away. And then and honestly, but when I left her office, I felt some hope for the first time in a long time. I felt like, wow, maybe I can get out of this place that I'm in. And yeah, so that's kind of what got me to where I was.
Well, thank you for sharing that and the vulnerability and transparency implicit in that. You mentioned a little bit about what your work-life balance was at that point in time, but were the biggest stressors all work-related? Are you able or willing to talk about what was going on from a family or personal perspective at that time that either helped or contributed to the degradation?
Yeah, I know that's a great question. So a couple other issues, right? I mean, so I had some health problems. I had, been diagnosed with ankylosing spondylitis, and in the late '90s. My arthritis was not bad. I mean, my dad had it. It was bad for the first couple of years, but by 2003, I mean, it was not bad. The uveitis bothered me. Your eye's not supposed to hurt. I don't.
Yeah, and eyes are an important part of a surgeon. I know your hands are valuable, but
Yeah, but
eyes.
you got to be able to see what you're doing. Yeah, exactly. That eventually is what got me to stop being a surgeon. I mean, I think that it seemed like, I mean, I don't know if it's true or not, but it certainly seemed when I got up to Hartford, I was taking a lot less call. When I was at Bridgeport, I was taking maybe 6 trauma calls a month, almost every month. When I was at Hartford, I was maybe taking 2 or 3 at most. So I'd have weeks and things would settle down, and then I'd have a really bad call and it would get bad again. And so, for a while I sucked it up, and then I'm like, I just got to stop. And so I do think that was a big contributor. I mean, again, I was fatigued, again. And also, one of my kids has some chronic health problems. And so, I think that there's a lot about the stress at home that comes into play. I mean, I think it's a really good point that you make. It's not usually just stress at work.
You mentioned a key distinction too, Michael. I heard you say, I went from burnout to depression. Some people confuse those two things or think that they are one and the same, interchangeable, but they're not. Can you talk a little bit about that and how maybe sort of burnout made you more susceptible maybe to depression?
Yeah, no, that's a great question. So the burnout, I mean, I look at it as exhaustion, kind of cynicism, fair bit of anger, kind of the deep end of burnout. You're starting to blame yourself for the problems around you. And I think that if you have the predisposition, as you start to blame yourself for things and feel like you're in a hole that you can't get out of, I think the burnout does kind of set you up for it. Yeah, when I was burned out, I was irritable, and I'm not normally an irritable guy, although I think, obviously surgeons have this reputation for being that way. I'm really not for the most part. But I'd gotten that way, but mostly I was upset with myself. Whereas in the depression, I was just sad all the time. I mean, I was really sad. And like I say, I lost joy, and, there's all this stuff that goes on with your appetite and activities and things. And of course, thoughts of, ending my life. That was just so I think there were some differences there between the two. Although again, when you're in the middle of it, I don't know when I transitioned from one to the other exactly, but somewhere in there.
As you were telling your story, and I felt like I was in the car ride with you across that bridge as you come to that realization. And had your family or friends come to the same realization? Were they pulling you aside saying, "Hey, here's what we see," or "Are you okay?" Or do you feel like you were containing it, hiding it, masking it pretty well? What was that like?
Yeah, I think that's a very important question for people, because we've all lost colleagues as well. No, I don't think that my family and my colleagues didn't know. I mean, they knew I was not normal, right? They knew I was, I mean, it was obvious that I was not in a good place, but I don't think nobody was like, again, if I talk to Phil and Dan, we talk about being burned out. because I think that was, again, people were talking about that in the trauma world. And so it was kind of a safe phrase to use, but we never really got into it any further than that. And I don't think my wife, like you say, you hide it. I mean, I've had a number of people, residents from back then and other physicians that I worked with that have talked to me since hearing the talk. And people just had no idea. I mean, I think there's a lot of stigma associated with this, and you don't want to let people know that you're feeling that badly. You just, that you're struggling. There's a lot of stigma around struggling with mental health issues, and so we're good at hiding it.
Yeah, we know the work's going to be hard, and there's going to be a lot of it, but you just keep your head down and keep grinding, right? And eventually you'll come out the other side. But it turns out that coping mechanism isn't successful for everyone, and probably not successful for maybe anybody. So do you think, I know this is going to be speculation, but looking back in retrospect, do you think there's anything that family, friends, colleagues could have done or could have said if they had recognized something in you that maybe you hadn't recognized in yourself that may have led you to seeking help sooner?
If someone had point blank asked me, hey, how are you doing? And it said, hey, have you been having thoughts of, harming yourself or ending your life? I it's hard to say, but I probably would have opened up, and I probably would have broken down, honestly. But yeah, I would have. I think that would have been one thing that could have got me help sooner. But then when I did talk to a colleague that I trusted and stuff, that is, where it all came out. So I think there is that. I think there is that possibility, and most people who die from suicide have never asked for help. Right? They never saw a mental health professional before they ended their life. I think there aren't many opportunities then for the psychiatrists and psychologists to intervene. So then it becomes, other people talk to them about it. I don't know. And again, it's hard for me to know. I did take the QPR training. QPR training, I think, was something I did recently. That's something people could consider about, because I don't think any of us really, very few of us, have a lot of experience talking to people about whether they're thinking of dying from suicide. It's not something we get a lot of training in, and so there is something to be said for that.
Yeah, there's this wide held misconception that if you ask somebody about suicidality, that's going to put the idea in their mind, right? But actually, it might spur the conversation. What helped you get better? Obviously it took time. There's no magic pill. It's not flipping a switch. We tell our patients that all the time. But what do you think really made the difference in the long haul to get you back to mental health?
So for me, I really felt. Again, this is just my experience, but I really felt the therapy helped. Like I gained insight into some of the things that I do that were getting me into trouble. Like I said, I would blame myself every time something went wrong. And it is good practice as a surgeon to reflect on cases that don't go well, but you can't ruminate on it, right? I mean, if you ruminate, reflect on it, learn the lesson, move on. And if you end up continuing to ruminate on it, and again, it's not just about patients and operations, it's about the running of the hospital and the department and all these your family life. If you ruminate on those things, you really. And so I learned how to recognize when I was ruminating on something and step back from it. I think that was for me. That was a really critical step, and then I was just able to start thinking more clearly. Started to think about the job kind of and the work we were doing more clearly. I think when you're depressed, you're not necessarily always thinking.
A surgeon, particularly who's lost his confidence and is not thinking clearly, is not going to have good outcomes and become self-fulfilling prophecy. I can see how it could degrade from there too. What do you think needs to change in order to help end stigma that's been attached to mental health among physicians particularly?
So I think the culture is changing. That's the good news. But I think that what needs to happen is there needs to be recognition, like what we do is hard. Patients get sick, they die, you get brought into these kind of nightmare situations on a pretty regular basis, depending on, exactly what kind of practice you have. And you try to sort things out for a lot of people, and it's very stressful. And so with that recognition that the work is that hard and that stressful, there needs to be recognition that just like I need to run to keep my heart strong, it's okay. And maybe you need to see a cardiologist or a primary care doctor. If you're struggling, it should not be a surprise, and it should be expected that you then go and talk to somebody. It's okay to ask for help. It's okay, and it should be, again, at some point, it should go from being it's okay to ask for help being like that's the right thing to do. I think, let me use the virus analogy. For most of my career as a resident, like if you had a virus, you came into work, right? I mean, that was the expectation. Like you didn't stay home. You had a fever. Oh, so what? You needed to come in. You needed to work. And now there's been a lot of change around that. Like it's like, you got a virus. Just stay home. We'll be okay. We'll be okay. We'll see you Monday, right? I literally had a conversation with someone today who works here. I'm like, man, I'll see you Monday. It's not a big deal. That the culture's changed that way. Mental health professionals have a lot to offer, and we should respect that and value what they bring.
So as somebody who's been through this, Michael, what would you say to someone who may be listening to this podcast right now, who finds your story uncomfortably relatable? Somebody who's been in denial about the degradation of their own mental health, maybe, and feels like you did, that it's a problem without a solution. Someone who's I had a phone call with somebody recently who said, I'm at the end of my rope, somebody who's ready to give up. What would you say to them?
Yeah. I just want to say, look, please reach out for help, please. And understand that like the treatments we have, like they work. They're actually quite, like therapy worked for me, but in the medications, it's not like we just have two medications, and at this point we've got a whole range of if one SSRI doesn't work, maybe another one will. Maybe maybe you need an MAOI. I don't know, but I mean, please stay with it, because every day I have things that I'm grateful for. Every day, I'm so glad that I reached out for help. And it can and does get better. Now that's not to say, look. Depression is almost like a relapsing thing, I think, for most people. So it doesn't mean that you're not going to go. I literally had a conversation with a friend this week who's now depressed again. That's hard, but he'll get through it, and his life will get better again for a while. And I just feel like it's so. Please, like life is worth it. It's worth the effort. I'm very grateful I reached out for help, and it was okay for me. I've had a terrific career. So I mean, I think if people are worried about their careers or worried about the stigma, look, I was able to do all this. Please just reach out. I mean, it's all the other stuff. So it'll work out.
Well, thank you so much, Dr. Michael Ivey, trauma surgeon and chief medical officer at Gaylord Specialty Healthcare, has been our guest. Michael, thank you so much for sharing your story. Really appreciate it.
Thank you.
Listeners can find the resources mentioned in our discussion today linked in the episode description. I'll also mention the 988 Suicide and Crisis Lifeline. Please ask for help. Talk to someone. You're not alone. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.